Okay, I think we are actually ready to sort of get started here. I think what we can do is do a kind of a quick roll call. We'll start with people on the telephone. Okay, we'll start with people in the room. This is Diane Feeney with HSCRC. Elsa Hiley, HSCRC.
I'm Tracy Laval from the Maryland Hospital Association, speaking for Bev today, who has lost her voice.
Linda Costa from the University of Maryland.
Ed Baranek, Johns Hopkins.
Justin Dybel, Mercy Medical Center.
Dan Cochran, Shady Grove Adventist Hospital.
Madeline Segal, Marvel Foundation.
Teresa Leeds, Maryland Healthcare Commission.
Allison Schuster, HSCRC. Julia Chelikova, HSCRC.
I did have email from a couple of folks who said they were feeling under the weather, that plan they were going to be on by webinar. So when they're able to pop in, we'll know they're there. We have people monitoring. Okay, so the first item on our agenda.
So all the panelists now are muted. If they want to participate, they would need to raise the hand. All right, you either type a message or raise your hand on the webinar, and Denise is going to unmute you. Thanks.
The first agenda item is the discussion of outpatient hospital measures, and that includes sort of an overall framework and then the measures themselves and the domains and subdomains. And we have a special guest speaker, Teresa Lee, who's going to talk about the work of the Maryland Healthcare Commission in the area, working collaboratively with HSCRC to implement the identification and requirement of data collection for these measures, which are new in Maryland, and then the implementation of that effort. So with that, I'll go ahead and ask Teresa to take the mic.
All right, thank you, Diane. What I'd like to do today is, as Diane said, give an overview of the outpatient measures that we will be collecting as of January 2014. And just to start with a brief sort of background about how we are at this place where we are now. The Maryland Healthcare Commission is required to report performance and quality information to the public to inform consumers and to monitor overall performance, as well as to facilitate improvement among hospitals where possible. We first released the guide in 2002, and the guide contains basic information on hospital characteristics, services provided, utilization using most common DRGs, length of stay information, process outcome measures, and charge information that comes from the HSCRC. And that's average charges for the top, I believe, 15 APR DRGs. In 2009, MHCC, in consultation with HSCRC, made a strategic decision to build the infrastructure to collect performance and quality measures data directly from hospitals. That way we could improve the timeliness of the data and would also enable us to evaluate the quality of the data. But prior to 2009, we would get this information from CMS, and it was aggregate information, and we really didn't have a good sense of its quality. So that was a major change that occurred in 2009. Over the years, the MHCC's priorities have been a little different from CMS. So since hospitals are not required to report, were not required to report these inpatient quality measures or outpatient quality measures, in Maryland, the measures that were available to us were quite different than those available to the rest of the country. And one of the issues we were focused on was HAI and requiring hospitals to participate in the NHSN surveillance system and capturing CLABSI data and surgical site infection data, as well as focusing on capturing information on healthcare worker influenza vaccination rates. So there was other things going on here that created a difference between what data is available in Maryland and what's available nationwide. So at about the end of 2002, the HSCRC requested that we expand our reporting requirements to include outpatient measures, and more specifically to expand the collection so that it's more consistent with what CMS is requiring. And that request was made in part to, and it was actually during the period where HSCRC had applied for the new waiver, and this information would help bolster Maryland's chances of getting the waiver so that we could show that we have similar information and that we're able to monitor our hospitals in the same way that CMS is monitoring hospitals. So in terms of the expanded performance data policy, in January of 2013, the executive directors of the HSCRC and the MACC issued a policy statement to all hospitals letting them know that effective January 2014, the measures would be consistent with CMS measures, and that would include outpatient measures as well. And you can see here this slide simply goes over the purpose of that, to strengthen our public reporting to support the quality-based reimbursement project that HSCRC sponsors, and also to support the new Medicare waiver. So these items identify the measures that we were not collecting at the time that are now required of hospitals as of January. The first 4 measures are inpatient related, and then the last 3 sets claims-based, chart abstracted, and structural measures from the outpatient side. Again, just to review, we now require a perinatal measure, elective delivery prior to 39 weeks, and certain web-based structural measures 4. And these measures are just requirements that hospitals report to CMS whether or not they participate in a specific database registry. Here you'll see the cardiac registry, nurse-sensitive care, and then a registry for general surgery. So it really does require that the hospital submits at one time during the year that they have participated in one of these registries for the, in this case, the time period would be for calendar year 2013. So it's the previous calendar year as a reference period. The expansion of the policy also included additional HAI measures. As I said, when MACC initiated its focus on HAI using the CDC NHSN surveillance system, we focused first on CLABSI and then on surgical site infections for CABG, hip, and knee. And now we are requiring surgical site infections for colon and abdominal hysterectomy to be consistent with CMS, as well as catheter-associated urinary tract infections in ICUs only. And then C. diff and MRSA data will be collected through, again, the MDRO module within NHSN. And we will also be using the CDC NHSN module for the collection of healthcare worker influenza vaccination information. And in previous years, we actually put together our own internal survey to collect that information, and actually have seen some really positive, some good progress among the hospitals. I think we started out at a 78% rate, and now it's about 96% in terms of the vaccination of healthcare workers. This slide simply identifies where there may be slight exceptions to what CMS is doing, and that is, as I've mentioned before, for example, CDC, hospitals are reporting hip, knee, and CABG in Maryland, and will continue to report those surgical site infections for those procedures, as well as the colon and abdominal hysterectomy that CMS is now requiring from hospitals nationally. The first item, hospital-based inpatient psychiatric services measures, are not required in Maryland for Maryland hospitals, and basically because it does require that if you have a separate provider ID for your psych unit, then it's required. And here in Maryland, hospitals don't have that, so we're at this point not required, and that creates an exception to the way in which Maryland reports versus the rest of the country. Again, as I said, in 2009, we established the Quality Measures Data Center, and it's comparable for those of you who know there's Hospital Compare, and then there's QNet, where hospitals submit their data. our Quality Measures Data Center is similar to QNet, and hospitals submit their HCAPs and their core measures data to us through that website and secure web portal, and they will be submitting their outpatient measures as well. As I said earlier, the outpatient measures consist of claims-based measures, chart-abstracted measures, and web-based measures. And the note here was I used this presentation for a couple weeks ago for our hospitals to just give them an update on the outpatient requirement. And one of the policy statements that we wanted to communicate is that if CMS retires a measure or if they delay implementation of a measure, then we will follow in that same. Is outpatient 15. I'll just bring to your attention that that measure has been postponed until 2016 by CMS, and therefore it's postponed for Maryland. And the way in which we will be getting the data for processing these measures is through some arrangement that we'll work out with HSCRC in terms of looking at claims data to get that. So there's nothing that the hospitals have to do there. There are 12 chart abstracted measures, and 5 are cardiac related. These are actually all related to care in the emergency department, median time to fibrinolysis, median time to transfer to another facility for acute coronary intervention, aspirin at arrival, median time to ECG. So these are all ED related measures for ED patients who are not admitted to the hospital. There are 3 Idi Throughput measures, and I won't read those off, but you can see the measures there. One of those measures has been removed. That's outpatient 19. And I don't know if there's anything else specific to those measures. I should also say feel free to stop me at any time if you have a question. So we're just about through this. In terms of outpatient 24, it's a chart abstracted and claims-based measure. I'm not exactly sure how that works, but that's how it's characterized, but it has been removed recently as well. There is 1 pain management measure, again, ED related, 1 stroke measure, and 2 measures related to surgical care on an outpatient basis. There are 8 web-based measures. Again, these measures are require that hospitals note through CMS, through their website, that they are either participating in, for example, Outpatient 25, a safe surgery checklist program, or that they have the ability, as in Outpatient 12, for providers with HIT to receive lab data electronically directly into their qualified certified EHR system as discrete searchable data. So again, you can look at these, and you have the presentations before you. These measures are required. Actually, the reference period here is for calendar 14, because when we actually put these requirements into place, it was too late to sign up for 2013. So hospitals will report next year whether or not they participated or complied with these measures, and that would be done, I believe, the reporting period July 2015 through November 2015. These are additional web-based measures. Outpatient 27 is requires that hospitals report on healthcare workers who received the vaccination, and they are to report this information through the NHSN system, similar to what we're doing on the inpatient side. I believe that CMS will be issuing additional guidance, and CDC will issue additional guidance to help hospitals determine how you separate out employees who may be working in either setting or how they want to handle that. So there's more information to come. And these are just resources for hospitals if they want to obtain more information on the measures, or if they have questions, there's a Q&A tool. So that concludes my presentation. If there are any questions, let me know.
So will you be providing these data also with demographic views so that they can be viewed? We can see different levels of disparities, race, ethnicity, geographic, gender, because we know there are disparities in this kind of care. So will you be able to?
We would have the we should have the ability to do that from the data. Our issue really oftentimes is related to resources. We spend so much time processing the data and getting it ready to at least, be prepared for reporting or preparing it for sharing with HSCRC that we really have not had an opportunity to do more innovative and forward-thinking kinds of analyses for reporting. But that is certainly something that we hope to do. And we're actually in the process of redesigning our hospital guide so that it not only includes hospital information, but it will be a single point of access for hospital information, long-term care information, health plan information, physician information, just so there's one access point. And we're hoping that by September of this year, we'll be able to have the first release of it, focusing first on hospitals and then expanding. Well,
I had a question about the web-based measures. Are they still detailed measures, or are they reporting? Some of them are structural measures I see, but some of them are denominators and numerators.
Mm-hmm.
Is that similar to how they do the clinical abstraction and submit the things, or is it?
With the structural measures?
No, the non-structural web-based measures that they have. Are they?
Yeah, but they're a little different because they do say web-based structural. So it may be they put in a numerator and a denominator, but it's still just a one-time data entry versus the ongoing abstraction of a record.
Right. The influenza for workers, I think, is...
That's a one-time.
Right, one time, but they are reporting the overall measure rather than, like, not a individual level measure. That's what I guess trying to do. So.
Yep.
Right. I think that's an interesting measure to point out because it's an important measure, and it does have a numerator and denominator, and it could have a lot of potential for having hospital attribution for that measure clearly, but it's not about patients. It's about the action of the hospital. So I think that's a really good measure to point out in terms of the immunizations. Then the other structural ones were whether there is a database to collect certain types of data. Right. One other thing that we may talk about in the context of efficiency or even the scorecard are some of the imaging measures which fall under the cost reduction area of the scorecard. Topical areas, and also do represent efficiency. Some of them we can collect, and Allison did some discovery on this. Some of them we could collect with Maryland's all-payer data set, and some we would be more dependent on Medicare Part B data. And some of them overlap with something else in your packet, which is the Appendix A monitoring commitments for the new model, which is why this document was stuck yet again in the packet, because there's some not complete but some overlap. But it also speaks to, like, for instance, for HSCRC case mix data, outpatient 10, 11, and 14 only could be derived because of how the data specifications are set up from case mix data. So in thinking about why this document's there, this speaks to how early and readily available the data are and from what source in terms of when we consider what to queue up for adoption, excuse me, in the outpatient arena for various purposes, for payment, for scorecard, for whatever we're thinking about. I think in general, outpatient is completely new in Maryland. And I don't know if there's thinking or feedback from folks at the hospitals about what's going on with outpatient data collection, where the hospitals are, how they're viewing this. It would be an interesting discussion because it's been happening in other states for 2 to 3 years now for many of these measures, but it is entirely new here. So that does suggest issues of queuing up and staging and how we put it in the queue for what purposes we have here at HSBRC. So with that, I want to throw it out there and ask questions. I don't know.
Other than to say, I think you make a really good point. It's new. Let's talk about it. I didn't expect the question, so I'm not sure.
Well, I mean, we're putting our toes in the water right now, and for real, these measures are implemented now. So they in order to be used for any purpose, they have to be in the pipeline, which is what we determined a year and a half or 2 years ago, and sort of how we got to this point. For those of you who weren't around during those fun times, so
I guess what I could say is, looking at all of these measures that were put together for monitoring, and I know we've looked at a bunch of measures for efficiency. I'm still having a little bit of a hard time getting my arms around what our plan is to do with the measures. I think in general we have a pretty good comfort level with measures that CMS is already using. We're fine with those. You know, if they're publicly available, they can be out there. We can have a very long list of things that we kind of keep an eye on, but we don't actively take action on. I think one thing that is very clear that we can definitely say is that measures that we want to highlight, that we want to say, we've done this, let's focus here, we should pick just a handful. And I think the waiver metrics, the complications, the readmissions, those have already been teed up. And I think they're going to be hard to hit those targets. So I want to caution us that we don't try to add too many things to the list to either tie payment to or to make a big deal about and draw our focus away.
I know, Diane, early on there was some concern from hospitals about the fact that we're sampling data. They'll be sampling data, so the volume may be quite small. So it may be a while before you have enough where you feel comfortable using within the initiative.
I think that's a good point. If I remember right, these outpatient measures in Maryland, a hospital can report them for what's in the regulated space, which compared to that universe that a hospital could report on outside of Maryland would be a bigger volume relative to the total. So that's how we get those smaller and
the regulated versus the unregulated,
right,
non-hospital ambulatory.
Right.
But at least most of these are ED related, but you still have some others, but they're ED.
Well, I think it's just sort of the first, the preamble to the first chapter of what will happen for outpatient measures in terms of, like you said, beyond implementation, what the various uses are. And it may be clear as we move forward in terms of how the context and the structure of the measurement, what things are obvious that should be added for the purposes that we need to have them. I mean, we have a set of waiver model monitoring metrics that were chosen before many of these measures were updated. So, you know, the back and forth of that is something that also is going on with
lots of this other work group activity as well.
I think that's a great point, that some of these measures we will incorporate into the quality-based reimbursement program and follow the principle that we had set up 9 months ago to say we're going to have this pipeline, follow the path that CMS follows, and that's sort of one track, and I think that makes sense. And it will be that QBR MHAC group that needs to get together in the summer. Oh my gosh, almost summer. That group that needs to get together to look at that program, and we can pick from here like we normally would. And then I think you make a good point about the metrics that are in the list to monitor for the waiver. We might just let that sit for a year. Not ignore it, but not try to change it and do anything with, just let it be. Focus on this other stuff, get these really important things kind of nailed down, and then take another pass around for these monitoring metrics.
I think to go with that, since many of these are the first time that we're actually gathering the data, I think it's helpful for us to understand that we're gathering the right data, we're looking at the right information, and comparing it against the benchmarks across the rest of the country that are comparable. As we know, CMS is primarily focused on Medicare. We've got everybody in the mix, so we need to understand the variance of those things with all of these various statistics as we go through them. So I think it's wise counsel to wait with any reaction or doing anything. We need to obviously start collecting, but we need to understand what it is in the numbers before we start focusing on doing anything with them going forward. And I do think with the ones that have been identified in the last, 9 months or so ago, are really the big focus right now for all hospitals, the avoidable utilization and so forth.
This is Beverly Collins. Can you hear me?
Hi, Bev. Yeah, we can hear you.
Okay, thank you. I have a question. Are the outpatient measures that other states have been collecting for a couple of years, you said, are they being publicly reported on Hospital Compare at this point?
I think there are some, yeah. There are a few. I mean, they got queued up, and then the list got added to. So to the extent there's been enough time to have the base and the performance period, et cetera, there are more than a handful, I think, that are up there. Okay.
And then sort of to get an idea of the burden on hospitals, do you have a total number of metrics that CMS is requiring? I know there's the inpatient and then the outpatient measures here. How many there are altogether, and then how many we would be proposing? Because you said some we wouldn't because of hospital ID issues and all that. So sort of what's the balance there of number of metrics?
Explain about hospital ID.
The psych measure is excluded because we don't have separate ID.
Right. Well, there are many dozens of measures, I think.
And in the contract, I think we have a specific requirement that, I don't remember the exact language, but IQR and OQR reporting systems that we are supposed to follow all the measures, at least on the regulated side. And the language, if I remember correctly, wasn't really clear if it would apply to unregulated facilities.
Yeah, this is Tom Valek. So if you added up all of the different things across the Medicare programs, IQR, OQR, VBP, Hospital Readmissions Reduction Program, the Hospital Acquired Conditions Reduction Program, and I guess you could throw in meaningful use too, right? As Diane pointed out, it's many dozens. One of the important things, though, about that I think we should be focusing on, because we have the opportunity to do things a little bit differently, is how all those program measures might align. So if, in fact, our opportunity is to look at, as I think Tracy was suggesting, the QBR as kind of the single place where all of these streams come together, we could avoid those duplications and overlaps among those programs. For example, some of the readmissions measures are in 3 or maybe even 4 of those programs, and it gets crazy making to figure out all of the incentives and just what's what to focus on in order to be successful under these programs. So we really ought to do a matrix that shows how all those things stack up, so that we can not only follow what CMS is doing, but do it in a smarter way.
That's a good suggestion. We like matrices. We've done matrices. We can do them again. But I think it's always nice to have a picture, and the ones that you've been maintaining for inpatient, outpatient are perhaps a good place to start to sort of appeal and add to, because you have the purposes of not only HSCRC, but a more fuller state picture of what we're doing with various measures.
I think we put in QBR for the public reporting, and then hospital compare and value-based purchasing. Try to put it all in one place. So we could combine the two. Thank you.
So this is Madeline. I have one more comment. In addition to the whole disparities piece and ability to have this inform local action, I don't really see anything except the SHIP measure that relates to behavioral health, and we know that's an enormous driver of costs and problems. There's a lot of change going on, a lot that we should all have our eyes on. So, and I know that you collect for health plans some really great behavioral health measures, but if we could have that incorporated, it feels like it's a whole right now.
And that's why we're hoping through the new website, will be the Maryland Healthcare website instead of just hospitals and long-term care, whatever, that we can pull some of that together. And then on that front page, sort of incorporate, start to integrate certain types of topics across settings. So trying to create the mechanism to do some of that.
I think we're probably should move to the next topic, but I appreciate the conversation about outpatient measures. Good suggestions. The next area what we were going to focus on was sort of have a preliminary discussion or our first discussion about the efficiency measurement report draft that we are, the goal is to have review and input from the work group and sort of make this report something that we feel is a group effort, and then can get to the place where we may finalize that this month. So I wanted to circle back to the efficiency draft report that was sent out earlier in the week. So,
and just to give you a background on the timeline, originally when we set up the work plan, the idea was to present it in May commission meeting if we were to have a specific efficiency measure to be used with fiscal year in July. Since I think when we had the discussion and everybody agreed that we really can work on creating an efficiency measure that is in line with the new payment models, that opened up time for us to really think about it and put some meat on the bone in terms of the details. Because of that, we kind of delayed, so it's not in the commission packet this month. We are hoping, for June we'll have something to present to the commission and get their feedback on. But by no means we are not planning to have a measure by June. So this is again a high-level direction and conceptual thinking. And in the report, in general, what we did is we summarized, thank you, Tom, a lot, his good presentation on the concepts and how they are all related to accountability levels and different perspectives, and then put the later part on the ROC, the reasonable of charges. And the only thing that I added here that wasn't discussed was the potential avoidable utilization. We discussed that in the quality measurement, but obviously you can consider them as part of efficiency too. So those are the three main parts of the report, but I would say it's very in an early stage. I think you would appreciate a lot of input from you to make the report more substantial for the commission.
So thanks, that's helpful. Thinking about what exactly do we want to maybe not exactly. What kinds of things do we want to have in the report? Is it our goal to have a recommendation to commissioners on we want to have this, that, and this as an efficiency measure, or we want to have something for case measure, a population measure? I'm not sure. I don't yet have a clear idea of how much do we want to recommend to commissioners. I heard you say we don't want to recommend an efficiency measure.
In detail, I meant. But I think in general, question is, do we still find ROC useful? What do you think? Or do we need to work on still trying to get a per case measure for some reason? Any use for ROC is a question in my mind.
Okay.
And second, between episode-based measures and PMPM measures, should we try to do both at the same time, or do you think it makes sense to do more PMPM type of measures if we are all under global budget? Or would hospitals still need to do? So there was we presented this at the payment work group, and there was a very good question. What is the difference between Medicare per beneficiary and the PMPM measure? In the episode, we are really looking at the hospitalization and the 30-day follow-up. Whereas the PMPM one, you're looking at a geography and you're calculating the total expenditures. Albeit it could be a hospital still, since we don't have the data, but it is a very different perspective. So I think the question that we would like to circulate back with you all is, given the differences between those measures, which measures hospital industry thinks would be useful from the implementation perspective, and eventually what measure we think is appropriate for creating a cost measure to just, to judge the efficiency.
Yeah. Those are good questions. I think in my mind, I still even have to take one more step back and say, what do we want that efficiency measure to do? So do we want that efficiency measure to tell us which hospitals are contributing most to helping or hurting in hitting the Medicare savings tax? That would be something I think we might want. I don't think we can do that in time for FY16. That would be hard, I think, because you would have to have a way to assign populations to a hospital, and I think that will take a big chunk of time. But that may be something that we work towards. You could say, and I'm not sure that I agree with this part, but another, as an example, something else you could say is we want to, you might say, what was the ROC used for? The ROC was used to evaluate a hospital's cost, or really charges more recently, charges per a particular case. Is there any value in that now? I think right now, particularly this year, probably even next year, when we're operating under a global budget and trying to reduce utilization, adding something like a ROC that looks at charges or costs per case is just the opposite incentive of what the global budget does and the opposite of what we're trying to do.
But to me, there is a difference between looking at the measure and knowing where they are versus using it for payment or policy purposes.
Yeah.
I kind of, wouldn't you still want to see what the per case cost is? You may not. Maybe that will create a lot of debate, but because at the end of the day, we have a mandate to have the charges reasonably related to the cost. How would we maintain that mandate? I think that's like what we are using the efficiency measure. I think that's kind of my take on how do we get that mandate measurement in.
This is another conference call.
I think that's a really good point, is to say one of our key things that we're trying to do with this efficiency measure is make sure that that the commission fulfills its mandate to evaluate whether an efficient and effectively operated hospital has adequate rates. So that's part of the efficiency discussion. which is, I think, what I heard in the question.
One way that this might be raised to the commissioners is to say, we have multiple, not necessarily competing, but we have multiple purposes for the application of an efficiency measure to the Maryland hospital all-payer system, and list out what those are and say, to go along with that, we have multiple options on how we might measure. And if we could get guidance from the commission on this is really what we want you to focus on in terms of the purpose of the program, I think it would be much easier to say this is the right measure for now. Perhaps this is the better measure for the future. But it seems like it's more, in some ways, it's more a programmatic question than it is a measurement question. I like the way that Sheila, you teed up all of those different questions about do we want this, do we want that, this measure does this measure does that, because we do have a lot of options, surprisingly, since cost of care is a tough area to measure. But we don't know exactly what we're wanting to accomplish at various points in time.
I completely agree. I think that would be great. That would be a great way to start the report to commissioners if we had some thoughts about that. Would it be helpful at all to potentially list some of those, what we might want to do with the measure? Would it be helpful to do that now, or do you want to, would you take that back and have us give you feedback offline?
Yeah, I mean, if you could, I guess the question, maybe we need to rephrase the question so people can think about it, is like the high-level question about what is the aim of efficiency measure, right? Is that,
you need the framework,
right?
And then once you have that framework of why, what are you looking at, why are you looking at it, then I think you can get down to how you do the measures. Going back to like Iraq or going back even further to the screens, because of the movement, I saw that. Things moving forward, those measures don't hold the same value, excuse me, that they did in the past. They served the purpose, and we were able to achieve through all those measures, including like the GIR, we were able to achieve goals, but there were specific goals that were set out when those methodologies were put in place. So when you going into it, this is the goal, these are the measures, and then as a hospital, health system, healthcare entity, you can develop your own processes to improve your position, to improve your results on the measure, and therefore move the state forward. So I think it's very important, though, to know, first of all, what's the framework, and then what is the goal. Then we can develop the measures, and then hospitals can figure out ways to manage under those measures to improve the performance. I don't know if that all makes sense. But
So what would you say the goal is?
you
want to take time and think about it?
Well, the other thing, too, that I think we have to be cautious of, we have about 150 different moving parts right now. And I don't know that we necessarily know how they're all going to affect each other. I think we have thoughts, but we have all of the different quality measures, the TAUs, then put on top of that the global budget arrangements, and then all the other numerous methodologies that are out there, and how do all those play into each other. And we're focused on just the hospital. This has gotten bigger than that as we move towards this the population health initiative. So it's all. I almost feel like do you really want to layer another thing on top, or are there things that are already existing within it needs to be within the framework, first of all and foremost. It has to be within the context of the waiver agreement. So it doesn't make sense necessarily to measure something that if you incent a behavior is going to go against the overall waiver performance. And sometimes we tend to do that. We will put a measure in place, but it'll be counterproductive to what we're ultimately trying to do as the goal. That's why I think getting that framework out there first is the most important piece. And I'd rather take our time and get something that's meaningful and it's going to help us achieve those waiver goals than rush out with something just to get something in place that won't necessarily help us get to those goals.
Yeah, Angie's smiling at me. You know, if someone comes for a full rate application, we also have a practical need to have an efficiency measure to be able to measure that. So I think one of the goals,
I think that's an important goal to articulate.
Right.
No, I understand where you're coming from, but I think if that's one of the goals, then we need to articulate.
Yep.
And in the past, that methodology that was used for full rate applications was tweaked, modified in order to create kind of a scaling and a redistribution. And that can be questioned again whether that is still a need or still appropriate. You know, so when you're establishing the goals, if you're just trying to have a tool that measures whether a full rate application is warranted or not, that's one goal. If you want to think what Ed was focusing on is a tool to help you reach your waiver goals, that could be another tool potentially. And then the question is, does it have to be the same tool? And you might argue, no, they'd be two different things. The rock, I mean, you asked the value of the rock. The rock was really a redistribution tool. I mean, it was used more for redistribution than it was for rate applications. You know, there's few rate applications that came through, but every year the rock was used for scaling for years.
Yeah, I mean, obviously the emphasis was on the top scale where hospitals ranked higher, 3% higher than they expected, and then scaled them down. On the bottom, if they were performing better, and then it was kind of up to them to come for, if my understanding is, up to them to come for the full rate application, right? Is that what you mean?
It was up to them, but that was the modification part, which is there were 3 other hurdles or so that you had to get over in order to disqualify. I mean, you could look, amazingly efficient on the rock, but still not qualify for a full rate application. So, yeah, that's a bit of the history of it, yeah.
One of the things that I mentioned when I provided the efficiency overview, which was sort of a framework, I don't know that it's exactly the framework that you're describing for our immediate purpose, but was that efficiency depends on the perspective of the user of that information. And I think that's what we're running into here. So that perspective might be the perspective from CMS looking at Maryland in the waiver situation, where population-based approaches were really emphasized. And I think we need to pay attention to that. It might be from the perspective of HSCRC, who has an oversight responsibility as a policymaker. It might be from the perspective of the hospital that's trying to run operations efficiently. And some of those things are changing under this new environment. So, for example, with a population-based or global budget approach, the hospital's view of operational efficiency may be shifting in a way that I think you guys are feeling and describing, that may be more aligned with where the waiver's going than maybe with some of the oversight responsibilities that remain in place for HSCRC. So perhaps if we're thinking about setting out some decision criteria for the framework, as I think you guys are describing it, to match ultimately to measures, identifying which of those criteria relate to which perspectives, I think would also potentially be useful to the commissioners.
Yeah, I think it's important to point out too, and one thing I'll add could be perspective of the consumer too. I don't think you mentioned that one, but achieving the waiver goals, I think most of the waiver goals are system level. But when you get into this ROC and efficiency measure, it's hospital level, and how you blend those two will be important, because you can go a long way to achieving the waiver goals by moving things around potentially, not necessarily talking about what the price is at one facility or the price is in another facility, but just in moving from one to the other, if you follow what I'm saying. So I think when you're looking at an efficiency measure and you're talking about ways to achieve the waiver goal, are you trying to achieve it statewide, or are you trying to achieve it at individual hospitals, and how do you implement that is an important question.
That following on that, that's a similar concept to the quality measures, where if there's a statewide achievement, then the individual hospital measures, penalties, reward is changes. Conceptually, maybe that's something to take into consideration, because if the goal is to move the state, to the extent the state is moving, and you're contributing to that, even though you may look higher or worse on an efficiency basis than other hospitals, is that as bad as if we're not achieving it and you're the reason we're not achieving it? There's a couple different ways to look at it. And I think kind of looking at the whole, because as a state, that's the important test as a whole, versus looking at the individual hospital. There may need to be a balance between the two.
Yeah, so if costs are higher in Baltimore City, or if costs are higher in PG and Montgomery County, how do you create an efficiency measure that then you can use to set the goals and or the rewards of the system, and encourage collaboration? Because you're not going to achieve those goals by one facility in downtown Baltimore doing something. If you really want to make strides in Baltimore City, you're going to have many or all of the hospitals collaborating in order to achieve the objective. So, we tend historically to look at all these things at an individual hospital level, and I think maybe what I'm proposing is maybe we need to think outside the box a little bit and think things differently.
You get an amen from over here.
Yeah. So if I could suggest then that we could continue sort of a electronic virtual conversation, that we could get, I've tried to take some good notes, and I know that Julie and Steve are taking notes, and we're all going to try to make the beginning of this report more consistent with the gestalt and the purpose and the setting up the framework and the questions that we're trying to answer here. And then we can get additional, even very detailed input on certain aspects of the report. If you want to do redlining, you can send it to me, and then we can set a date by which we can expect the comments, and then recirculate a draft. And do folks feel like another conference call after review the draft of the work group would be useful?
Yeah. So I think, so if I heard right, sending out kind of maybe an outline of this beginning part, and a round of comments on that bit of outline, and then once we've got that, then another revisions to the report, and then send that out to is that right?
That sounds fine, yes.
Okay.
That's better said, thank you.
We're all building, one builds off the other, right?
So I think the next week time frame, we got to keep moving this along. So within a few days, we would get this turned around and back to the group. and then we could, begin the back and forth, and then think about when and I might pull for a call time in 2 weeks' time, for instance, so that we have a date by which we're sort of moving. Is that good? Sure. Okay. Great. Well, this was an interesting conversation as a precursor to the next topic on the agenda, which is a balanced scorecard or dashboard conversation. In last time's meeting, we set up a context in which this dashboard or scorecard would be used by us here, policymakers, leaders in organizations, to review hospital/system performance and look where there may be some areas that needed further look underneath. So the purpose was to be sort of an early warning or a guide, but not meant to replace any other very deep and important measurement that was going on underneath. So it was meant to select a group of measures that we thought were representative in the various domains that address back to the triple aim that were in the model, so in the original contract. So there's a Venn diagram of about 10 different things that overlap with in lots of other areas here that we've been talking about. So it's in that context, though, that I want to re-ask the question, because does this need to have a statewide, does this need to be a statewide system dashboard because of the comments you just made about thinking outside the box? So let me ask that as the first question.
I would start with a yes. I think to the point that was made earlier that if we as a state are meeting the goals in a really good way, if everything's looking like green, go ahead. We're really hitting the readmissions and the complications, and Medicare costs are going down. Then I think it's not as important to have a look at what's detailed underneath that, particularly from the regulator point of view. Hospitals, I'm sure, are always going to be looking at a much deeper level because they're trying to drive that improvement. But I think that first big statewide look is important. And I would almost tie this balanced scorecard to that efficiency framework.
Well, I didn't mean to get an unqualified yes to that question, but I asked. I suppose tonight. I think. Okay, so we think about the quality programs. We've been doing these for 5 or 6 years now. We do not abandon individual hospital achievement. We set up measurements that are individual. We also reward and penalize for good and a good performance and performance that we would like to see that is addressed. We know that the incentives are going to drive how directly performance on the individual things. So I think if I could suggest that maybe this was, should we add that view, not abandon the hospital system view, is what I want to say.
I would reinforce that. It's not an either or kind of question. In fact, you would want your measurement and your public reporting at multiple levels to be reinforcing in kind of a drill down, roll up kind of way. So I think what you were ultimately getting at, Diane, which was how do we take what we've been doing, thinking about at a individual hospital level, and also make that into a meaningful overall assessment in terms of a statewide dashboard.
So I guess what I'm thinking is if we're talking about, we've already got the quality metrics and we look at them on an individual hospital basis, are we talking about making a dashboard that has, here's readmissions, and you take another look and here's hospital-specific readmissions, or here's complications at a specific level, I think that's fine. I don't know if we're ready to, I would caution on showing individual hospital readmission rates in particular to the public without a lot of explanation about why you can't compare a 13% to an 11% and say that we know 11% is good and 13% is not as good at two different hospitals. I guess what I'm saying is I'm cautioning again about us. I don't want us to pick new measures to go on a balanced scorecard when we've already got the couple that we need to focus on, and we've talked about a bunch of other ones that we can monitor. So again, I think we need to stay focused on the key things that we have to hit in the waiver targets, and I just worry about putting other measures up there that are not those. Right? So, well,
let me just say one more thing. If I hear you correctly, you know, we have the monitoring. One of the ideas was we have this list. If you think this is comprehensive enough and not too crowded, this could be our scorecard, right, the monitoring. But what we felt was this was still a huge list, and whether we can prioritize some of those from this list particularly and then elevate them to a higher level for more scrutiny. But if you are just concerned with the targets, that's actually half of the first page, performance target data, which are a handful. And I think from my perspective, you want to understand a little bit detail. I think in the last meeting we talked about having actionable and measurable measures, and I would be very uncomfortable to propose, okay, these are 4 targets we have, and let's have only those to be in the scorecard. The other idea for the scorecard was to monitor some of the unintended consequences, to highlight some of those measures out, and kind of create the protections, at least from the monitoring side, to be able to see those kind of measures. For example, I'm thinking about transfers. Not, you know, we are not discouraging or encouraging, and we just want the best place for the care. But I think that's, for example, one trend that is not in any of those lists that might be in our scorecard, so that you kind of look at that transitions of care or changes in the care patterns. I think that was kind of our thinking in terms of trying to get the monitoring list. If there are any holes in there, and I think behavioral health is a big hole, I agree with Madeline there, and then see if, you know, if people feel comfortable with the whole list, this could be our scorecard. But if you think this is too detailed,
how often do you think you would, like, what would you do with this scorecard? How often would it be refreshed? Would it be posted somewhere? Would it be like released? You know, what would we do with it?
I think, and the question that goes with that is, what's its purpose? If we're developing a scorecard that is to reflect how the state's doing as a whole, if we're, you know, I think to the balanced scorecards we use in the hospitals, and we've got many of them depending who it's going to. We could have it at the department level. We could have something that's going to our board that's a more global, but then there's detail under that that goes to a different population or stakeholder to review. And the further down you go, obviously, the more detailed it is. But you can't really take action on what's going to the board. That's really this is how we're doing in total. The action needs to be taken at the detail level underneath. So when we talk about an actionable scorecard, I don't think the two necessarily go together, because the scorecard is more of how we're doing overall. The action we're taking is at a much deeper level, I think. So I just want to make sure who is it that the audience is for this scorecard, and then what are we trying to prove or show with this scorecard?
As Dan mentioned, I think the audience is the commission and the stakeholders. So the hospitals, you want to see the state level one, and then have ability to customize it for your organization and go deeper. You know, we have the monitoring Maryland performance reports. They are financial reports. Maybe that's a good analogy to think about. We already added the PPCs and the readmissions to that report on a monthly basis. But that ends there. You know, there is no population health measures, nothing else. So maybe what we are talking here is creating a new monitoring Maryland performance report, which we term scorecard, that is more in line with the three-part aim and with the new new waiver. Cool.
I just have another question.
Nicole, microphone.
Thanks.
So actionable by whom? Because when I look at these measures, some of these are things that hospitals cannot impact. There are things that state agencies could impact. There are things that other settings could impact. But when you look at, you know, home health caps or nursing home caps, I mean, those aren't things that hospitals.
But this is a monitoring list. This is not a scorecard. So
No.
what I'm hearing from you is those are probably not candidates for a scorecard because they are not actionable.
Right. I just wasn't sure there was agreement on, so the scorecard's only going to have the things that are actionable by hospital.
Is that what you want to do?
Otherwise, it seems, unless there's a coordinated effort by state agencies to engage other providers outside of the hospital field, that doesn't seem appropriate.
Mm-hmm.
I'll comment on a couple things that a couple folks said, and the first is the either-or comment. I think that, at least from my perspective, we fully appreciate the fact that, you know, individual hospitals will be held accountable for certain things, and there'll be measurements and comparisons. But I think getting back to Dan's point about different scorecards for different folks, if you're talking about the commission and the audience is the commission, I think one of their main objectives should be how is the system doing overall. So as an example, you talked about population health measures. One of the biggest challenges that we have right now is attributing population to individual hospitals, right? So that doesn't mean that the commission scorecard can't look at population health because it's in the waiver and that's what we're trying to track and measure and so forth. But then all your individual policies should be geared at driving a result in that balanced scorecard. It's not actionable per se at the population health measure statistic where you're going to take that statistic at an individual hospital, but yet you have all these other policies that kind of are underlying that objective and that goal. And I think that's kind of what I was getting at. The scorecard is kind of saying, how are you doing? But then you set individual policies that are all kind of geared towards driving that result on the scorecard.
Mm-hmm. Yeah.
So that's a good maybe segue. If we could, Maddie, you have a look of, you want to say something?
No, I'm agreeing.
Oh, okay. You want to turn your mic on because I think you're going to be talking now. So let's just start with that because the SHIP measures are something that we did highlight in the last meeting, and maybe the SHIP measures are something that we could look at a regional or a statewide level. And there's three areas that you gave some feedback between time, which was ED, behavioral health, and infant very low birth weight, were the three areas that you thought were ripe for investigation in the conversation of the scorecard. Now, there are copies of they were handed out last time, the SHIP measures, but Idi has some that if we want to look back at, they don't completely overlap with the ones on the monitoring metrics, so that's why you get to have two more pieces of paper. Sorry about that.
So again, SHIP measures, the goal was to drive local action that was collaborative. So it could be cross-hospital with primary care, behavioral health providers, public health. So none of these were ever created to evaluate one party of all of the work that's being done. But the beauty of these and why they're referenced in every one of our hospitals' community benefits reports now is that they do show disparities. Most of them, you can see what's going on. We have enormous disparities that are also associated with a lot of excess costs. So really, in efficiency, they have efficiency impact, and that they can be provided at local levels so that you can see what's going on in different areas. So they're pretty actionable. But the ED measures, which we only were updating annually, could be updated quarterly, and they're huge numbers, so you can see a lot. You can look at them in a lot of ways. So the ED measures are really helpful for what's going on in the system, particularly around our potentially avoidable utilization. I said very low birth weights because we do have a lot of very low birth weights. That's not what's here, but it could be easily. SHIP could be modified to have very low birth weights because that has long-term costs, and there's a lot that could be going on in the public health and primary care systems to get at reducing those.
Just one thing, it's a peculiarity, not actually, and Andy can speak to this, in some babies that were very low birth weight, their costs were in level 4 SOI, their costs were inversely associated because those babies didn't survive. So the low birth weights may actually be more costly if we do, I don't know, but I'm just.
Maryland does very, very poorly by national and international standards on low birth weights, and there are big costs to that. And early intervention, you know, identification and intervention of people at risk makes a difference. It's cost effective and could speak to, you know, possibilities, new possibilities for collaboration.
Do you have your SHIP measure list? Because that is measure number 3, reduce the percent of low birth weight births.
Yep.
Okay.
I have them memorized.
I know. Oh, you didn't need the list.
No. Well, I didn't get one, but.
Okay. So there are, if we want to get a little bit specific about a couple of the ED ones and a couple behavioral health ones, or if they're amenable to a roll-up, I don't know that they are, but I'd like to ask that question.
So one of them is the 3 that have big population health impact are, there's probably more than that, there are 4. Definitely ED visits associated with hypertension. I mean, that's very top in terms of, it's under the chronic disease measure. Sorry, I should, okay, 28. I have them memorized, but not by number. So that one, and especially now in my role with Medicare, quality and disparities is just huge. And it has tremendous value for everyone here to be really looking at that because it can drive action. Also, ED visits associated with diabetes, which should be right next to that, 27. And those are particularly good for adults and the elderly. ED visits associated with asthma, huge for children, but also Maryland ranks at the bottom of the nation or close to it for adults with asthma and potentially avoidable utilization. So that's another one that, and it's also very sensitive to intervention. It can be improved, and it's cost effective to do so. And then also the ED visits related to behavioral health. This is the singular SHIP measure with the biggest numbers. So if you look, you can look at what's going on in the tiniest county, and you'll have numbers big enough where you can splice it on, you know, like a quarterly basis by race, ethnicity, and age. I mean, they're just huge numbers. So there's a lot of cost, and it does speak to really access issues. It is a huge access issue. That, again, there will need to be solutions that are not just in something in the hospital's control, but it's something they've got to be maybe driving, you know, improvements with the other partners Nicole's talked about at the state as we're, you know, moving towards behavioral health integration. Leadership could have good payoffs here, but I think more importantly, it's going to stand in the way of the waiver goals if there isn't attention to it when there's so much transition right now in systems that weren't working that great to begin with. So I definitely recommend those as critical, and I think they'll just be helpful for targeting. Access is also important because we know that now we have a lot more Medicaid people covered by Medicaid, but if they can't see a doctor and there's no one who will see them, you know, that's something you're going to want to have knowledge about. And so this measure of looking at, and I think I saw Tricia in the background who's helped us with this, but looking at past 330 days, whether someone, particularly children, but other vulnerable populations, have had a wellness visit. So something that wasn't urgent care is something, again, that could be sensitive to intervention, making it better, that has costs, like are high-risk people actually able to, or seeing a doctor? So that's one that's ready. It's here. It's here somewhere. It's in the last section. Let's see. So it's number 37, but there's an ability to look at that measure across ages. I think I can say, Tricia would. We started with adolescents because we know that that's when kids stop seeing a doctor. Very young children tend to, but then as they get older, all kinds of risks, they don't anymore. So that's why we looked at it. But so those would be my top list. And I know you have like overall life expectancy, stuff like that, but I tend to favor the things that are more actionable that I just mentioned.
Actually, I apologize for the members of the other work group. We invited and we didn't acknowledge them. And we have space around the table. So we have members from the data and infrastructure work group who are here for Jonathan's presentation. But they also reviewed the same, we've been talking about the same measures and trying to come up with sources where we can get that. And they also had some valuable contributions to the measures themselves. So I think you can join us on the table. With the mic. And if you could introduce yourself so people get to know you too.
Forgot my game. Sally Alborn, and I'm on the Data and Infrastructure Work Group, and I'm the CEO of Maryland Community Health System, an FQHC network, and part owner of Priority Partners Managed Care Organization. I just had a follow-up question for Dr. Shea because when I looked at the adolescent measure, I was sort of taken back. The other one, you know, I get. But your comment about the fact that adolescents drop off of getting care at that point, which is our experience, and my question was our target low, that we have a green dot, or are we really doing really well?
So the target.
What's said in this group can stay in this group.
So really, they're all posted online.
So we started from baselines, and our targets were all informed by Healthy People 2020 because they had a huge consensus process to come up with targets. So, and this is just Medicaid, this data, the data source for this one. So, so we must be doing better, that they're seeing doctors more than they were.
I'm just confused because I think every single MCO got slammed in the last value-based purchasing on this measure.
Yeah, so a green light would mean it would speak to a level of improvement from the prior year.
Oh, so this
it's just looking at improvement towards goal.
Oh, this is a year-to-year improvement.
Yeah.
Oh, okay.
Yeah.
All right. All right.
And I didn't do this year, so I can't say exactly what the improvement was, but that's what that means. Yeah.
One moment. Sean Tunis, who's on the line, wants to have something to say, I think. Sean, did you want to make a comment?
Oh, no, actually, I just wanted, since I was muted on the other end and I had some comments earlier and wasn't able to make them, I just wanted to make sure I was in control of my own muting, but nothing to add right now.
Okay. All right. Thank you. Okay. So I don't mean to abruptly end that, but I thought that was really good, and I thought that the points about, you know, system-wide accountability, perhaps regional, that this type of measurement was amenable to that on a scorecard was a good part of the conversation.
Can I ask one question about that? The measures that you highlighted make sense to me from just the point of view of I haven't looked at any data, and I can see the tie between these and the potentially prevention quality indicators. I would imagine they tie pretty closely. Could we check that PQI data to see, are these?
The PQIs are only inpatient side. These are emergency.
Yeah, true.
And we don't have anything on the emergency, so I think that kind of addresses both the population health side and the other one.
Where I was going to go, though, with that was that the diagnoses seem similar, asthma, diabetes related.
Yeah,
so
right.
Even though this is an emergency department visit, if to the point Justin was making earlier, if we have a scorecard that includes some population health measures, we want to put things on there that are related to policies that we also have. So we're not going to have any policies about the PQI, the ED department visits for diabetes. We don't have a policy on that. We haven't been talking about a policy on that. So would a PQI related something? I think Maddie's probably, she's got her ear to the ground on these things, so probably right on target. You're not, it looks like
I'm kind of, because the measurements of PAUs, PAUs are in development. We kind of prioritize inpatient, but a year from now, I don't know if it's going to stay the same. And given that we don't have any emergency, the reason why we didn't have emergency because, frankly, ARC didn't have one. There wasn't any publicly vetted measure where you can really look at the avoidable. I think there might be some details that not all the asthma, visits to the emergency may not be avoidable. So I'm not familiar with the literature, but our definitions to me, are the only for fiscal year 15, and we are in the development of expanding those measures.
Yeah, and I would also say I think this is probably a good example where the individual policies don't have to be a one-to-one tie to what's on the scorecard. They just have to support the improvement of what's on the scorecard. So, for instance, PAUs, at least what I've seen, the most current version does include 30-day revisits to the emergency department, which some of these would probably be in that bucket. So, you want the policies to support the overall goals, but I don't think it has to be it's on the scorecard, here's the policy. It doesn't have to be that concrete.
Well, and you know that in Maryland, the top for 30-day readmissions and for ambulatory care sensitive admissions, the two top diagnoses are hypertension and diabetes. And I guess COPD is right in there, and CHF. But so it all goes together.
And hospitals will just work that backwards because they're trying to reduce the readmissions, which come from the emergency department, which they'll try to get to the point where they can reduce the visits overall. So I do think that the policies are supporting many of these, I guess, was my point.
And I'd just like to circle back to Justin's comment too, because one of the things we haven't talked about is access, and actually his comment about who is the audience for the scorecard, and if it's the commission and its ability to measure how effective we're being in achieving the goals of the Medicare waiver, which I think should be the objective. Access to me needs to be tied into all of these, because I think that a lot of us think that anecdotally, that one of the issues we're going to be facing as we move out, further into the implementation of the waiver is access. The more hospitals begin to push care out into the community, the more pressure there's going to be both on the primary care and the specialty care providers. And access, I think, needs to be tied. So to me, when doing a balanced scorecard, what you want to look at is a series of measures that fit into each other like a puzzle. And to me, access is one of the big ones, not just at the primary care level, because I can tell you from the FQHC world, whether it's an uninsured patient or even a Medicaid patient, we have enormous difficulty getting timely referrals to specialists. We wait weeks. You can get a primary care visit faster than you can get a specialty care visit. So, I think those two also need to be bifurcated. But at least that's this is just sort of a holdover, as you know, Shuli, from the data work group.
Thank you. If we could switch topics and gears quickly to a couple of the mainstay quality areas where we do have hospital level measurement and we've been comfortable with it, or perhaps not as happy with performance, but there's two subset measures from that list, which are the patient experience, or HCAHPS, and then the MHAC scores, which certainly directly relate to our waiver target and are measured at the individual level and have an incentive-based structure. Those are two candidate measures we thought would be good to put forth for the scorecard. Go ahead.
Can I just make a comment? On the HCAHPS, I saw you pulled out the 3-item care transition measures, which I think is fantastic, because I'm not sure how well recognized they are, but those are essentially from Eric Coleman's work, and they're valid, they're reliable. But interesting, I went on the Hospital Compare just to take a look at a couple hospitals. I couldn't find those 3 questions.
Right.
Oh, is that what it is?
They just started January.
Oh, okay. All right.
But your point about them is great. So I think we should absolutely focus on them when the data is available, because they speak to a lot of other things like that
readmission, recidivism. There's been a lot of research showing
studies and correlations with those.
Good. Oh, great. Okay. Well, I couldn't think of why in the world aren't they there.
Yes.
Okay. All right. Thank you.
And then another area we thought were readmission rates as they're going to be measured for success under the all-payer model, but with the exclusions that we've put in the algorithm because of the hospital comparisons and it being unfair without the appropriate exclusions. So those are those measures to ponder that we thought would fit. And then these couple areas of innovative models and physician participation, we somehow don't see those on this scorecard right now. On the big monitoring list, yes. And then for the unintended consequences, or I'm sorry, for the other part of Maddie's discussion on inpatient care, there's the ARC measures that do address. There are 3 composites: prevention indicators for acute, prevention for chronic care, and then there is an overall composite, I believe, but there are 2 composites, one for acute and one for chronic, which what those are comprised of are on the following slide. So the 90, 91, and 92 PQIs are, you can see what makes those up on the next page.
So going back to making it kind of actionable, we thought that it's, rather than reporting the overall composite, it's probably more helpful to have acute and chronic. And they are in the current state stat reports as well, so it will align with that one too.
And then the next one's the unintended consequence of ED or observation or transfer. Those issues within 30 days we thought should be monitored from an unintended, potentially unintended care pattern shift or unintended consequence. And then with data sharing through the HIE, that was another target area on the monitoring, or I'm sorry, on the 3-part AIM for the model. And one of those areas could be there is an encounter notification system, but it's sort of at a system level. It's how many providers. Currently there are over 1,100 that participate in the ENS. That means when their patient goes to the hospital, who gets notified. So that may be a more appropriate system level metric. And then we talked about SHIP. And then we have a bunch of cost measures that are, I think, are these are ones that may be on monitoring Maryland performance. This is in context of that conversation, revenue and
so the total cost, we are monitoring the total revenue in state, out of state, so that's one. We have separate line for Medicare versus the other one, that's the other one. And in addition to the total revenue, I think it's still important to look at the volume, but I wasn't sure with our equivalency, would it be simpler if we have the inpatient admission number as something to trace, or do you think the volume is? And Commission has in the Monitoring Maryland Performance, they would understand that number, but if you are still thinking about this more of a public report at the same time, you may want to think about if we are doing a volume number to look at it, what it could look like, if any.
I'm sorry. Can I go back to? I guess I'll ask the question there. Have we answered the question yet? Whether we're looking at these on slide 6, the first bullet, those measures for the aggregate of the state or at a hospital-specific level? And I have that question too about the measures on slide 4.
So this is aggregate at so if we were to do hospital one, then obviously it's the global budgets. If they are, that's kind of a monitoring compliance tool for us. But eventually, if we, come up with an efficiency measure that ties with the goals of the Medicare savings and all-payer population health per capita, that could be then the hospital level one. Right now, it's at the state level, all these measures.
So when we're talking about the scorecard for this discussion, the things on slide 4, we're talking about at the state level, at the aggregate.
Right.
Okay.
But since these are easily producible at the hospital, would you not want to see it at the hospital level?
I think
you have
for these PQIs, it's hard to do at the hospital level because you'd have to define the population that goes with that.
Mm-hmm. Right. That goes actually. That's a good question. In the total cost one, we are calculating the total cost, and that could be, how I think.
On slide 6.
You want that at the hospital level, so they can see what is the total avoidable volume that they have.
Right. On slide 4. I'm sorry. I'm right. Okay.
So slide 4 has the actual rates of these encounters.
Mm-hmm.
Slide 6 under PQIs has the cost, residual costs related to these encounters. So one of it is a cost and one's a rate.
And you're right. Rate is state level. You won't be able to calculate it until we come up with an attribution. But the total cost, we do have a percentage of total PAU cost for each hospital.
Yeah. I'm just a tiny bit uncomfortable with that because I think that the socio-demographic factors influence that.
But again, I think the judgment on the scorecard at the state level is our performance.
Yeah.
The one at the hospital one is for them to compare and find opportunities to achieve the goals. Right? Would you think that it will be used for comparative purposes?
I guess my question is, I don't disagree with you that looking at that it's a valuable look at different hospital PAU costs, but I'm questioning whether the commissioners are the right audience for that look, or are the hospitals the right audience for that look at the hospital level.
I think maybe another way to say what you're hearing is probably a hesitancy to show a ranking of something that has unexplained differences in it. So when you're showing a ranking, and you actually said it earlier, I think, when you talked about the readmissions, and actually I think you put it in your policy too, where you're not comfortable saying what the readmission risk-adjusted should be by hospital, so you just want everybody to improve.
Right.
Well, the nature of the beast is if you show a ranking of hospitals and their percentage readmissions, people draw conclusions, based on, oh, well, their rate's 18 and their rate's 14, so 14 must be better. When if you haven't risk adjusted it, you don't really know that answer. And I don't want to speak for Tracy, but I think that's all you're hearing, which is, maybe we can develop a scorecard that's global by region for the commissioners, and then all these other individual policies we can kind of work on at the staff and hospital level.
Yeah,
I think it's important for us as staff to understand if certain hospitals or certain systems or certain hospitals in certain regions, certain types of hospitals are having a disproportionate impact in some of these, we as commission and our commissioners would be interested to know that maybe something's not working from a regulatory standpoint related to these types of hospitals, or maybe something else is going on in the environment or the industry that we need to change. Incentives may need to be changed. So I think it's important, whether it's public or whether it's something that we're going to do a ranking or whatever is something we can talk about later. But I do think it's important for the commission to be able to have the hospital system, regional, hospital type level data that reflects to understand what the total state metrics are showing and why.
Agreed. Agreed. And I just think it's about that caveat. It's about making sure when they have a chart in front of them that they understand we haven't risk adjusted this and you can't really compare it and so forth, at least.
And perhaps, and we do this on occasion when we do the pricing guide, we sometimes will show both risk adjusted and risk adjusted. That's a whole different issue we need to talk about, whether all these are lend themselves to appropriate risk adjustment. But there are times where we will show online both and try to explain, and we'll explain what the difference between the risk adjusted versus non-risk adjusted is.
And that kind of reminded me earlier discussion we had on the readmission. Remember the risk-adjusted quality improvement versus the pay for performance? To me, I'm looking at this from a more quality improvement perspective. And yeah, I think we can find a balance not to put out information that will be misused without any warnings. I think that, yeah, I think we're on the same page there.
And I just want to reiterate, because I kind of snuck in a recommendation there that I don't know if it came fully out. But when we're looking at the scorecard, I think it might make sense to look at regions in the state.
Yeah.
Baltimore City, D.C. corridor, East, West, however you want to group them. I think that might be of value.
So, however, what level do you think is more appropriate, like county, or is it more than regional?
Well,
think about it. You don't have to answer right away, but.
Well, my preference would be to have regions that are manageable. So if you do county, I forget how many counties are in 20-some, right?
24.
Going back to my middle school days. So that's kind of a lot of counties. My guess is you could come up with 4, 5, 6 regions that are more manageable for the data.
Last but not least, because Maddie wouldn't have it that way, is the reduction disparities. We can look at many of the quality measures, certainly all the SHIP measures, ACAP, through that lens, so that we can see how we're doing at a statewide and probably regional level as well, certainly. And we would not forget about that. I'm sorry to rush, but I know Jonathan Weiner sitting, and I probably didn't manage to end it perfectly well, but I apologize for that. I'd like to invite you to come on up, and we're going to switch to now a new topic because, well, we know that Jonathan's presented to Donna and others thus far at the commission, and in the area of population health and patient-centered care and the use of tools in health IT, the intersection of those things is where Jonathan's been doing some very targeted and exciting work, and we did invite him to come and present about that work to us today. So he has advanced our thing. And
thank you, Diane, everybody. People know me know that I speak very loudly and I'm very talkative, but today I'm a little hoarse, so I apologize. But I'll try to hold my own, and thank you for the mic and for your time. The first thing I want to say is this is perhaps the most important activity in 30 years for Maryland, and I just really want to say how impressed with what you've done so far, and the charge that you take is really phenomenal, and anything I can do to help, I will. And I say what I mean, both good and bad. So I really mean that. And I think that there are a lot of reasons why it's happening. Many are in our control. Most are not in our control, but the stars are in alignment. And it's not just, well, actually, most people in Maryland aren't watching. They don't know about this. They're paying attention to the not so great web rollout, even though health reform's doing very well, thank you. But this is big. And I think that one of the main weaknesses of